हाय गाइस, दिस इज़ डॉक्टर शिवम एंड चलिए आज एक ऐसा क्वेश्चन पढ़ते हैं जो कि आपके नीट पीजी में पूछा जा रहा है। पहले जैसा पैटर्न तो अब रहा नहीं कि आपको वन लाइनर वो पूछेगा और आप फट से जवाब दे देंगे। अभी क्या है, बहुत ही इम्प्लाइड क्वेश्चंस पूछे जा रहे हैं एंड लिटिल बिट एडवांस्ड क्वेश्चन पूछे जा रहे हैं। इस शॉर्ट वीडियो में हम एक ही क्वेश्चन डिस्कस करेंगे that is related to your nose anatomy, and that is your identification for anterior and posterior ethmoid arteries. So they have already asked about aganesi in your last exam. They asked is what is the anterior most ethmoidal air cell in the given picture. So they had given this picture, and the anterior most ethmoidal air cell you all know is our aganesi cell. Now if I ask you what is the most constant what is or which is the most constant anterior ethmoidal air cell, then it will be your bulla ethmoidalis, right? Bulla ethmoidalis. So this is I think you all know, and this is just to make you revise. So anterior most ethmoidal air cell, if they ask, is your aganesi, and if they ask what is the most constant, then it is your bulla ethmoidalis, right? So which is the anterior most ethmoidal air cell in the given picture? It will be aganesi. Most constant it will be bulla ethmoidalis, right? Now अब मैं किस लिए ये वीडियो बना रहा हूँ, because this has very high probability of being asked in this examination which is going to be held in 2023, it is 5th of March, right? So they have started giving you nasal endoscopy pictures, they have started giving you CT scan pictures. So how you will identify? First is what is this structure, and second is whether it is anterior ethmoidal artery or it is posterior ethmoidal artery, right? So this is a axial, this one is a axial cut like this of a nose and paranasal sinus scan. Now सबसे इम्पॉर्टेंट होता है आपका कोरोनल कट्स में, बट अभी मैं आपको जो दिखा रहा हूँ वो है एक एंडोस्कोपिक पिक्चर जिसमें यू कैन विजुअलाइज दी एंटीरियर इथमोइडल आर्टरी। ये जो आपकी आर्टरी जा रही है ये एंटीरियर इथमोइडल आर्टरी है। अगर मैं आपको इजी लैंग्वेज में इसका कोर्स बताऊं तो ये ऑर्बिट से निकलती है ये आर्टरी एंड नेजल कैविटी में जाती है, एंड देन through the nasal cavity it enters into the cribriform plate, and then it enters inside the skull base, right? So ऑर्बिट से निकली नेजल कैविटी में आई एंड देन क्रिब्रिफॉर्म प्लेट्स में घुस जाती है। तो अगर ये पार्ट हम माने आपका ऑर्बिट है, ये ऑर्बिट से निकली, ये एक बोनी कैनाल के थ्रू जाती है, जो कि इसको ये कभी कभी बोनी कैनाल नहीं भी रहती है, हम ब्लड वेसल ऐसे भी देखते हैं, और ये फिर इंटर कर जाती है इनटू दी क्रिब्रिफॉर्म प्लेट। ये जो दिख रहा है आपको इज योर एंटीरियर इथमोइडल आर्टरी। क्यों इम्पॉर्टेंट है? बहुत बार फेस करते हुए, एंडोस्कोपिक साइनस सर्जरी करते हुए इसका इंजरी हो जाता है विच रिजल्ट्स इन प्रोप्टोसिस। बहुत बार आप देखेंगे, कई बार क्वेश्चन पूछते हैं आपके एग्ज़ाम में कि वाई ड्यूरिंग नेजल सर्जरीज द आई इज़ केप्ट ओपन of that side of the operating side. इसलिए because if anyhow the surgeon injures this artery, what happens is many a times this artery gets retracted inside the orbit. ये ऑर्बिट के अंदर घुस जाती है और फिर अंदर ही ब्लीड करती रहती है। जब ये आर्टरी अंदर ब्लीड करती रहेगी तो क्या होगा? आई ऑर्बिट इज़ अ कॉम्पैक्ट स्पेस और अंदर ब्लड जम रहा है। जब ब्लड जमा होगा ऑर्बिट में कंप्रेशन होगा, ऑर्बिट आई बॉल जो है बाहर की तरफ निकलेगी और ऑप्टिक नर्व में कंप्रेशन आएगा, एंड ऑप्टिक नर्व इज़ अ वेरी सेंसिटिव नर्व फॉर इश्कीमिया। ऑप्टिक नर्व इश्कीमिया, राइट? ऑप्टिक नर्व की इश्कीमिया हो सकता है रिजल्टिंग इनटू ब्लाइंडनेस। वी हैव टू प्रिवेंट optic nerve damage in this scenario. Early identification is important. That is why we keep the eye open on the side where which we are operating. और अगर बाई चांस ये ऐसा इंजरी हो जाता है तो आपको इमिडिएटली क्या करना होता है, बिकॉज आर्टरी को तो आप पकड़ नहीं सकते, यू कांट कैच होल्ड द आर्टरी बिकॉज इट हैज़ इंटर्ड इनसाइड द ऑर्बिट. इन दोज केसेस what you should do is you should do an emergency lateral canthotomy. So they can give you a scenario where they can say कि you operating canthotomy, right? So you are operating on a nasal polyposis case, and while operating you observe the eye getting bulged or proptosis. You suspected anterior ethmoidal artery injury and bleeding. What is your next step? So your next step will be lateral canthotomy, right? And one more thing you can do is your orbital decompression, right? So you can do medial orbital decompression. इसमें हम लोग क्या करते हैं, इसमें हम लोग को पता है decompression, इसमें हम लोग को पता है, हम सबको पता है कि जो आई होता है उसका जो वॉल होता है, जो मीडियल वॉल होता है आई का, उसको बोलते हैं लमाइना पेपाइरेसिया, राइट? ये एक थिन पेपरी बोन है, लमाइना पेपाइरेसिया. सो दिस थिन पेपरी बोन इज फॉर्मिंग अ वॉल बिटवीन द ऑर्बिट एंड आवर नेजल कैविटी. सो इट इज़ द मीडियल वॉल ऑफ द ऑर्बिट, लमाइना पेपाइरेसिया. सो इसको क्या करते हैं, वी रिमूव दिस लमाइना पेपाइरेसिया विद द फ्रीयर्स इंस्ट्रूमेंट. सो एक इंस्ट्रूमेंट से इसको निकाल देते हैं. अब क्या होता है, जैसे ही बोन निकालते हैं वैसे ही क्या होता है, जो फैट है, ऑर्बिट है, उसको जगह मिल जाता है रिलैक्स करने का, राइट? सो जो कंप्रेशन हो रहा था वो कम हो जाता है, और जैसे ही कंप्रेशन कम होगा सो ऑप्टिक नर्व के ऊपर प्रेशर कम होगा, तो इश्कीमिया नहीं होगा. सो यू विल बी सेविंग द ऑप्टिक नर्व. सो इमरजेंसी इज लैटरल कैंथोटोमी and medial orbital decompression in case of anterior ethmoidal artery damage, right? बहुत बार क्या होता है, we just cauterize this artery, right? It's a very thin artery, बहुत मोटी नहीं होती है, so हम cauterize करके बंद कर देते हैं. But there are situations where this artery retracts into the orbit, and whenever it goes inside the orbit, then all these dangerous thing happen, right? So one of the complication of endoscopic sinus surgery, face functional endoscopic sinus surgery, is blindness because of this anterior ethmoidal artery injury or direct optic nerve damage, right? So ये तो एक चीज़ था. अब confusion कहाँ होता है कि how you will identify it on CT scan. So अगर आप देखें, so एक बहुत ही important question पूछा जाता है जिसको बोलते हैं Kennedy's nipple, right? So Kennedy's nipple, ये क्या होता है Kennedy's nipple? So Kennedy's nipple is a CT scan finding. यहाँ पे हमको क्या मिलता है, आप देखेंगे ये जो ऑर्बिट है, ये हमारा दो ऑर्बिट है, राइट? सो हम बोले कि एंटीरियर एथमोइडल आर्टरी इमर्जेस फ्रॉम द ऑर्बिट, राइट? और ये हमारा क्रिबिफॉर्म प्लेट है, लेट अस सपोज. सो इट इमर्जेस फ्रॉम द ऑर्बिट, इंटर इनटू द नेजल कैविटी, ये आपका नेजल कैविटी है, और देन फाइनली इट इंटर्स इनसाइड द स्कल बेस थ्रू द क्रिबिफॉर्म प्लेट. सो ये जो साइट ऑफ एग्जिट है फ्रॉम द ऑर्बिट इनटू द नेजल कैविटी, इसी साइट को हम बोलते हैं कैनेडीज निप्पल, राइट? सो यहाँ पे कोनिकल प्रोजेक्शन होता है इसके निकलते टाइम पे, और इसी लैंडमार्क को हम बोलते हैं कैनेडीज निप्पल. अनदर इसका सिग्निफिकेंस है कि ये जो आर्टरी निकल रही है, सो अगर आप ये देखिए ये साइट है, राइट? सो यहाँ से जो आर्टरी निकल रही है, आप देखोगे कि इट इज़ एग्जिटिंग द ऑर्बिट बिटवीन सुपीरियर ऑब्लिक एंड मीडियल रेक्टस. सो यहाँ पे दो मसल रहती है, ओके? मैं आपको कलर चेंज करके दिखाता हूँ. मानिए कि ये आपका है मीडियल रेक्टस, ये है आपका सुपीरियर ऑब्लिक, राइट? और आपकी आर्टरी निकल रही है इसके बीच से, ये, राइट? सो दिस artery एक और क्वेश्चन पूछा जा सकता है इसकी, दी एंटीरियर एथमोइडल आर्टरी एग्जिट्स बिटवीन सुपीरियर ऑब्लिक एंड मीडियल रेक्टस at the site called Kennedy's nipple, enters into the nasal cavity, so ये आपका nasal cavity का part है, and then it enters into the cribriform plate, so ये है lateral lamella cribriform plate का, ये है medial lamella cribriform plate का, ये है crista galli, right? So ये lateral lamella में घुस जाती है ऊपर, and again it comes and supplies the nasal septum, that is another part, but अभी के लिए इतना याद रखिए. So अगर इधर देखेंगे तो ये है आपका Kennedy's nipple का site, right? So CT scan है, so you can't see blood vessel, but you can appreciate the bony and the soft tissue. So here will be your superior oblique, here will be your medial rectus, this artery is exiting through this, and this is the canal of anterior ethmoidal artery, right? So अगर हम सब चीज़ इससे delete कर दे, then you will be better able to see and appreciate again. So ये साइट है आपका कैनेडीज निप्पल, ये है बोनी कैनाल जिसमें कि एंटीरियर एथमोइडल आर्टरी ट्रेवल कर रही है. नाउ टेल मी व्हाट इज दिस. इफ समवन हैज पॉइंटेड एरो ऑन दिस, व्हाट यू विल से. सो अगेन दिस इज योर, टेल मी वेदर एंटीरियर एथमोइडल आर्टरी और posterior ethmoidal artery. So don't confuse, this is again anterior ethmoidal artery. I will tell you how to identify posterior ethmoidal artery. First you see this is same or similar CT scan as we had discussed. Here you can see Kennedy's nipple, and this is the bony canal in through which this anterior ethmoidal artery is traveling and entering into the skull base. Now tell me, what is this? Is this the same Kennedy's nipple? No, this is not Kennedy's nipple. Here you will observe this canal is for posterior ethmoidal artery. Now you will ask me, sir, how I will identify? Here also we can say see a conical structure, and why it is posterior ethmoidal and not anterior ethmoidal. देखिए, इसके लिए आपको थॉरो नॉलेज होना चाहिए सीटी स्कैन का, बट मैं आपको एक यहाँ पे इजी चीज़ बोलता हूँ. इजी चीज़ क्या है? जस्ट ऑब्जर्व द ऑर्बिट. ओके, आप ऑर्बिट को ऑब्जर्व करो. दिस इज योर ऑर्बिट. सो what happens is anterior ethmoidal artery is anteriorly, posterior ethmoidal is little behind, पीछे की तरफ है. So orbit कैसा है हमारा? conical structure है, ऐसे बड़ा है, and then as it goes back it is coming like this, cone छोटा होता जाता है, ऐसे है, ऐसे, and then छोटा होता जाता है, right? So पीछे की तरफ छोटा पार्ट आएगा. So orbit अगर आपको छोटा दिख रहा है, small like this, and they had marked this conical structure and this canal, then it will be your posterior ethmoidal artery. Just see the comparison, right? Here you see this big orbit, right? So this is your anterior ethmoidal. Another thing is you will anteriorly anterior ethmoidal, so you will be able to see frontal sinus in the CT scan. Here you see there is no frontal sinus, this is whole skull base, right? No frontal sinus because पीछे की तरफ है posterior ethmoidal artery. So आपको easy करने के लिए मैं ये दोनों को फिर से दिया हूँ. Just see which one is anterior ethmoidal artery and which one is posterior ethmoidal artery. You see orbit का size देखिए कितना बड़ा है, यानी कि anteriorly होगा, right? So this is marking for your anterior ethmoidal artery. यहाँ पे orbit का size देखिए कितना छोटा है, सो इसका मतलब पीछे की तरफ है. ऑर्बिट जो है कोन है पीछे की तरफ, सो पोस्टीरियर एथमोइडल आर्टरी, राइट? सो डोंट मिस्टेक इट, राइट? एंड दिस इज जस्ट योर बोनस क्वेश्चन. आइडेंटिफाई द इंस्ट्रूमेंट यूज इन ENT surgeries, whether it's a jaw retractor, Doyne's retractor, Mollison's mastoid retractor or Boyle's retractor. So you are going to comment in the below section which is this, right? And I'll post the answer. एक बार रिवाइज कराई देता हूँ. मोलिसन्स सेल्फ रिटेनिंग hemostatic mastoid retractor used in mastoid surgeries, temporalis tympanoplasties for harvesting the temporalis fascia, mastoidectomy and head neck surgeries like tracheostomy and all. Why it is self retaining? Because यहाँ पे देखिए, यहाँ पे एक सेल्फ रिटेनिंग सिस्टम है. और हीमोस्टैटिक क्यों है? बिकॉज ऑफ दिस प्रेशर एंड ऑल. सो वो प्रेशर से हीमोस्टेसिस भी मेंटेन कर देता है. This is your Jaw's retractor, this is your ये Doyne's retractor, right? And this is your Boyles-Davis mouth gag used in tonsillectomy and adenoidectomy. Another important question is mechanism of voice production after total laryngectomy. So total laryngectomy rehabilitation is also important. I'll make a separate video if you want. Comment me if you want this, about studying about laryngeal CA, which is a very important topic, laryngeal CA and its operation called total laryngectomy and rehabilitation. So if you want, I'll make a small video, just important points. And this question was asked, so I'll just give you a brief idea. Mechanism of given prosthesis used for voice production. So what is happening here is there is a prosthesis that is inserted inside the laryngectomy stoma. So this is a prosthesis inserted by creating a fistula called tracheoesophageal fistula. So this fistula is communicating the trachea into the esophagus. Air will enter from this lungs into the esophagus to produce the voice. So this is your, we have to close the opening to speak, so that whatever lungs, the air that is present in lung, it enters through this fistula into the esophagus and the person can speak, because we have removed the voice box of this total laryngectomy patient. So this is tracheoesophageal fistula. So it's a surgical procedure. Speech production is uh, like you have to put the finger and then you will be able to means the patient will be able to produce. The prosthesis, voice prosthesis, is called Blom-Singer's prosthesis. Blom-Singer's prosthesis, right? And these are different modes of rehabilitation: esophageal speech, electrolarynx. This is the electrolarynx. People, the patients push or touch it in the larynx, which produce some signals, electric signals, so that they are able to speak. But the problem is the voice is very robotic. Now in the end, as I was discussing the nasal anatomies, I want you to see the normal nasal anatomy, right? So I'll just show you one normal nasal anatomy picture video, so that you can identify all this. So this is a first pass diagnostic nasal endoscopy. So our DNE has 3 passes. This is first pass, where we go along the nasal floor. This is, you can see the choana. This is your tubal elevation. Here is your eustachian tube opening, right? And behind this tubal elevation is fossa of Rosenmuller. This is your inferior turbinate. This is your nasal septum, right? Nasal septum and the inferior turbinate. Now let us see our second pass. So first pass was along the floor of nasal cavity. Second pass, we go between the middle turbinate, this is your middle turbinate, and the nasal septum into the sphenoethmoidal recess. So basically we are seeing the sphenoid ostium, superior turbinate, supreme turbinate in this second pass. This is your middle turbinate, this is your nasal septum, and we are using a 0-degree optical endoscope to do the second pass. And similarly there is one third, that is the third pass. So third pass is basically once you do this first pass, like you reach till choana, then once you are withdrawing your endoscope outside, you, what we do is we swing the endoscope and enter into the middle meatus. So in third pass we see the middle meatus, that is between the middle turbinate and the lateral wall of nose. Okay, so what all you can see, this is the middle turbinate. You can see the uncinate process, you can see anterior, you can see bulla ethmoidalis, uncinate process, behind will be bulla ethmoidalis, and between the uncinate and bulla is, now you have to comment here, between uncinate and bulla ethmoidalis is a 2-dimensional space that is called query. Comment me and tell me. This 2-dimensional space leads into a 3-dimensional space called infundibulum, right? And this infundibulum has your maxillary sinus ostium, right? Now this is another uh, clip where we are showing you a surgical steps of FES. So the first one was uncinectomy. Now this is your bulla ethmoidalis. So here what the surgeon has done is he has opened the frontal sinus, and frontal sinus basically we can't open directly, so we open the frontal recess, the pathway through which frontal sinus drains. So this was the frontal sinus. Now the surgeon is opening the anterior ethmoid cell, that is bulla ethmoidalis. So this is your opening of bulla ethmoidalis. So once you open the bulla, what I want to show is I want to show you the anterior ethmoidal artery, how it looks like in a DNE. So once you open the bulla, you will observe that the anterior ethmoidal artery is lying behind the bulla and below the frontal recess. So you just see how the surgeon is clearing a way to anterior ethmoidal artery. So you see this is your anterior ethmoidal artery. Once you remove the bulla, so they can give you a video clip like this where the surgeon is doing this and they will say what is this structure. So this is your anterior ethmoidal artery. So don't mistake. Always remember, the questions are not going to be same like before. They are always and always innovating new questions. So the previous pattern is not going to help. You have to keep on innovating, you have to keep on getting the concepts rather than just remembering and cramming the stuffs. So that is why my focus was to give you the exact orientation that a surgeon have, because these questions are being framed by the professors who have the in-depth and conceptual knowledge of the anatomy and everything. So the main thing is, the main purpose of this video presentation, I am doing it late night after all my duties, private practice and all, is to give you enough faith, right? Is not to make you worry but to help you out, so that if something which we know as practicing surgeons, if we can give you our perspective, then you will also understand the things in a better way and you will be able to answer things rather than just saying the paper was very tough, because this type of orientation is needed, which is lacking these days because of busy seniors, lots of load in the hospital and etc and etc, and so much of competition, right? So you are also not able to attend the OTs, the wards. Why? Because there is so much of, if you don't read then you are out of game, if you attend wards then you are lacking somewhere. So I understand your situation. That is why I am here giving my extra effort for your help and hoping that
Good morning everyone, this is Dr. Shivaam from India.
like it.
Today I want to explain how we have to control anti-ethmoidal artery bleeding.
So
Never hear about this anti-ethmoidal artery in first surgery. It is just 0.9 mm. It is just 0.9.
So I hope that you all will get benefit from it, and in the end, the one thing that I want to remind is, you only fail when you stop trying, right? So you need not to worry about what rank you are going to get. Just keep on working, keep on revising the stuffs, have faith in yourself. Whatever you have read is going to help you in your main exam. This feeling of forgetting everything is very normal in this stage. Just remember that whatever you have read from your first year days, everything is going to help you in your main exam, right? This is not a game, this is not a short run, this is a long, it's a marathon. You have been in this field for last like 6-7 years, right? So everything that you have gained, try to use all your knowledge in the exam, and don't worry, you will be able to do it, right? Everything is going to come into your mind when it will be needed during the exam, right? So don't ever give up. This is the most crucial last days of your exam. Keep working, keep pushing, keep revising, keep giving GTs, and I'm waiting to hear the success story, the struggle, the sacrifices, and the winning smile and the story of yours. Till then, be happy and stay confident. This is Dr. Shivam signing off.